will now head into our first talk by Dr. Duane Mole. Duane is a very accomplished otologist who's in private practice in Johannesburg. And Duane's also a member of the Johannesburg Cochlear Implant Program. And he's going to be talking to us today on a very interesting and I think quite a difficult concept, Duane, on how to manage the small airborne gap. So I think we're all very interested to see how you would negotiate this difficult area. So over to you, Duane.
Thanks, Session. I appreciate that. I'm going to just quickly share my screen here. Let me see if I can get this working. Okay. And then we'll go to that. Are we up and running there?
Yeah, we can see your slide, Duane.
Just says the managing the airborne gap. So
Yep,
I think like everything in life, welcome and good evening, everybody. I think like everything in life, you start out and you think you've got a great idea and you've been working on this for a while. And then when you put it together, you realize you've bit off far more than you can chew. And there's a lot more that needs to be said about this topic. So I'm going to start in the introduction just telling you what we're not going to talk about, briefly discussing some of those topics, and then we'll get into what I really wanted to talk about. But just for fun, the picture on the left-hand side, I know it's a little bit out of view, out of focus. That was, I had the privilege of attending Hugo Fischer's skull base course when he was still alive many years ago. And this was my temporal bone specimen. Can you believe it? So that's a persistent stapes artery, and you can see it there around the anterior crus of the stapes. Anyway, let's move on. What do we mean when we say small airborne gap? Well, I was thinking of more than 15 decibels, but less than 25 decibels. We're going to try and stick to that because I think less than 10, I don't think any of us would attempt to repair in any way. So we're talking mainly about those kind of audiograms that you see in front of you. Those are the kind of audiograms that you sometimes faced with, and you sort of say, well, should we do something? Should we not? And that's pretty much what we're going to talk about. So let's look at some of the causes of a small airborne gap that we're only going to briefly discuss tonight. And I'm going to start with one that's obviously in the literature very prominent, the semicircular canal dehiscence. This is really a very real cause for a small airborne gap. But as we know, it essentially does not repair. That means the hearing does not repair with the superior semicircular canal dehiscent. That condition, if you plug it or you resurface it, it doesn't really do much for the hearing. There's a lot of other benefits for doing that, but it doesn't do much for the hearing. So we haven't found that to be a huge benefit. We're going to talk a little bit more in detail about that. The whole issue of tympanic membrane perforations, and really that's huge. You know, the size of the perforation, the location of the perforation. And I actually did a big study on this a couple of years ago when I did a talk. And it was very interesting to find out that probably, yes, the bigger the hole, usually the larger the airborne gap, but we still get those massive tympanic membrane perforations, or very large ones with a relatively small gap, especially in kids, and then those pinhole perforations with a large airborne gap, which obviously probably has ossicle involvement as well. But one thing that was a positive predictor, or something that they could really predict, was your middle ear volume. So your perforation with a small middle ear volume had a bigger airborne gap than with a large middle ear volume. So your mastoid pneumatization was a big predictor. Anyway, we'll talk about that now. False audiogram representation of an airborne gap. And I think that's very important just because, you know, we so often say, well, it's the audiologists, and please, I'm not knocking them in any way. They do their tests, they're accurate as they can be, but there's a lot of things in an audiogram and on the actual measurement of the bone conduction that is very, how can I put it, unsure in certain frequencies. And this gives us those false airborne gaps. And so I'm just going to be pointing out what we need to look out for. We're hardly going to mention anything about middle ear effusions. Just remember they're also there after trauma, you know, with the hematuria. So just be careful about them. And then external ear canal casts or wax occlusion, those are straightforward. However, I'm going to just briefly mention something about medial canal fibrosis. So let's jump in straight into semicircular canal dehiscence. Now, if you want more on this, I'm sure Louis will be able to give us a talk at some stage. This could be a talk totally on its own. I'm going to just make a few statements, and the little case that you see up there, the little audiogram, is one of my patients with a left semicircular canal dehiscence. So usually, in general, according to the literature, the airborne gap is mostly below 2000 hertz, usually mainly between 300 and 900 hertz, obviously in the low frequencies. The gap is anything between 10 and 25 decibels, can in rare cases go up to as much as 50. I've never seen that myself. However, that is what the literature says. The trick here is that bone conduction is usually better than expected, and you can actually see that very nicely over here. I don't know if you can see my cursor in the, you get sort of a -10 at 250 there and a -5 at 500. It's better than the other side, which you can see on the right-hand side. And that should be the sort of trick to say, hey, let me just look a little bit further here. There might be a third window effect. And we know that it paradoxically enhances the low frequency bone conduction transmission because of the situation of that third window. What about a normal air conduction hearing with clear semicircular canal dehiscence on cone beam? I'm going to show you a case. I don't have an answer for that. I'm just putting it out there as a question. It's a confounding one, if we can put it that way. When do we treat these guys, and what do we normally treat them for? Treatment is mainly focused on the symptom relief, really. So again, hearing doesn't really respond well to treatment in these cases, but the Tullio phenomenon, the Henneberg sign, and the autophony really do well with, for example, a plugging, etc. And just remember, obviously, on the VEMPs, you've got that abnormal low threshold VEMPs, which is nice and diagnostic of these cases. So that's just our case, just a little bit larger situation. I want to show you just, for those of you that maybe haven't been familiar with a semicircular canal dehiscence, this is an anterior semicircular canal dehiscence on the right-hand side over here. I'm just going to page through it, and you can see this is on a cone beam. And I must say, guys, it's really difficult to call this on a standard high-resolution CT. I find that a cone beam much more accurate in this situation. And there you can see it going all the way around on the right-hand side over here. Okay, so that's very clear. We can all see that. I'm just going to move it forward and back just to give you that feeling. And obviously on the left-hand side, you can see that although that's thin, that's definitely still intact. All right. Okay, then we've got an interesting one. So here we had a bilateral semicircular canal dehiscence and a slightly fixed malleus. This malleus was actually touching the dura. So I'm going to show you the pics. It's on the right-hand side again, so keep your eyes over here as we pan through. Here you can see the dura actually touching the malleus. Now, there was no reported surgery. There was no tumor on MRI, but that's how the patient presented. And then they had, let me just move on, superior semicircular canal dehiscence, but quite a significant one you can see on both sides. All right. And that was really out, and then it only comes back in over there, you know. You can see it there. It's not so prominent on the left-hand side, but it's definitely open over there. Here on the right, it's quite a huge piece that's open, and then it sort of comes in over there. And that was just, again, that audiogram. That was quite big. So that's where the so-called 50 could come in. I'm not so sure. I think the malleus played a role here as well. This next case this was my audiogram with a bilateral semicircular canal dehiscence on cone beam CT. I'm just putting it out there. This is the exact case. This is the patient. And there you can see clearly on the right, definitely open, clearly on the left, definitely open over there on cone beam. Yet that's my audiogram. Just putting it out there. Don't have an answer. I think the jury is still out there exactly with this condition. Maybe, Lou, you can give us a talk at a later stage on that. Let's look briefly at this effect of the tympanic membrane perforation size. So we know that AB gaps are generally largest in the low frequencies when we see a perf, and they decrease as frequency increases. So we see the biggest, obviously, here around 250, 500, closing at about 1,000, and then 2, 3, and 4 are normally closed, essentially in standard perforation sizes. Yes, generally, the airbone gap is larger with a perforation size at each frequency. But what about the perforations in the anterior and the posterior quadrants? Now, as I said, I've done quite a lot of reading up on this as I gave a talk a few years ago. And the interesting thing, and I've just left the article downstairs that was probably one of the better ones, is there was no significant difference in the airbone gaps other than the lower frequencies where there was a 5 decibel difference better in the anterior perf rather than the posterior perf. So being the posterior perf, you're closer to the sort of stapes area. So, you know, did that so-called round window phase have an effect? Well, I was always taught this, and I certainly believed it. However, on the studies, interestingly enough, they could not prove that. They could not prove that round window phase cancellation, you know, the concept that the sound would go through and actually hit the round window directly, and you'd lose the columellar effect, where if it hit the eardrum and sort of vibrated through the ossicles like that. Although, you know, we preach this, and some of us believe this to be true. I must say I was a believer until I did a couple of research on this article. That seems not to be as true as what we think. Let's look also at the thing that I did mention earlier, and that was the small middle ear volumes. So small middle ear volumes, that had a significantly larger effect on the airbone gap than ears with large middle ear volumes. So obviously mastoid pneumatization played a big role in terms of the airbone gap size with your perforation. So I think that's something to keep in mind when we're looking at TM perforation and airbone gap. And there, that's what we're seeing there, sort of some of those small ones, some of those big ones. There's all the different spaces where you can get, if you're describing your perforation. And it was just interesting to see that anterior posterior perfs didn't have that much difference. I'm talking about the small ones. Okay, let's move on. This is the one I wanted to get us to maybe talk about because it's something we don't really know too much about. And that's a false airbone gap that you see from the audiologist on the audiogram. And we're very quick to operate on an airbone gap that's possibly on an audiogram. Head up, think twice. We don't operate an audiogram. We operate the patient. Everybody says that, but just in a reminder, the occlusion effect, that's really where the minute you put, especially in masking and counterlateral masking, the minute you put insert earpiece to test the hearing on that side, you are causing a false sort of bone conduction blockage. Like when you put your finger in your ear and you hear your speech in that ear. So be careful about the occlusion effect. This gives us a false elevated bone conduction level. We'll talk a little bit more in detail now about that. Obviously, the vibro-tactile sensation that we see, and this is very much the case in the low frequencies. These are often perceived rather than they're felt, rather than actually perceived as true sound. So just be careful about those low frequencies. This was an interesting thing in my studies. I realized that putting that bone conductor behind the ear, if you're just a little bit off, and it can be as much as 1 centimeter to the left, 1 centimeter to the right, you can actually get a difference of up to 10 to 15 decibels in bone conduction. And that was very interesting. They put it down to a number of factors, but one of them is obviously that all our mastoid bones are not the same. We don't have the same aeration. We don't have the same skull thickness. We don't have the same scalp thickness. And then there's the hair, especially our ethnic hair. Some of the guys battle there. So there's a couple of factors that play a role, while this can actually change just by the position of that bone oscillator. And that can then give us a false airbone gap. Interestingly enough, air conduction is very well calibrated. It's easy to test, it's easy to confirm, and it calibrates well. But bone conduction is actually calibrated on an artificial mastoid. Thus it's not a true bone conduction for each patient, and that's obviously impossible to test. So bone conduction is different for every person. There's a slight difference for those factors that I've just recently mentioned, that all of us is a little bit different. And so just remember that although your calibration of most of the audiologists use the B71 system to test bone conduction, that unfortunately has that limitation. When we talk about excessive masking, most of us are aware of this. This is when you have very good hearing on the one side and poor hearing on the other side. And it's just, you cannot mask that good ear enough to take away the bone conduction effect that the bad ear is going to hear in terms of, hearing it contralaterally. And so that is also got to be very careful. So the minute you've got a really unilateral significant hearing loss, you've got to be very careful about believing that airbone gap, with all your heart. Again, in our older patients, remember the ear canals are really small. They're close to collapsing already when you look into them. So if you can put headphones on those ears, just the external ear canal can collapse quite easily and give us that bone conduction or false bone conduction elevated levels. I always remember that a high frequency airbone gap in an audiogram in an elderly patient should never go to surgery unless the rest of the audiogram corresponds. And that is just because you're getting this collapse of the soft tissue of the external ear canal, and especially around the 4,000 hertz frequency, that is a problem. Okay, so that's just in a brief sort of graph form. Where are we worried? So if we look at the top here, you'll see the high risk is at the 250 hertz mark. You'll find there's something called a harmonic distortion. What that really is that if you are testing at 500 hertz, there is a harmonic in 10 to 20% patients that is heard at the 250 hertz line. And so you might have normal hearing at the 500 and bad hearing at the 250, but it's normally heard because of a harmonic effect, and you get a false airbone gap. Again, the input, the B71 machine's output at 250 is limited. And so sometimes if you've got a genuine sensory neural hearing loss in your 250 range, your your air conduction will be down, say, at 70, but your bone conduction just can't drop lower than 40. It just can't. That's just the limitation of the machine, and 40, 45 maximum. And then it perceives as, this is a low frequency hearing loss. This must be a malleus fixation or a stapes fixation or something like that. So be careful about that. The placement variability, we talked about that. That's just where you place the on the mastoid, the air bone, the oscillator for the bone conduction, where exactly it's placed on the mastoid. And that can give us a effect. And then you can see this green line over here. That is the occlusion effect. And it's amazing how significant it can be, giving us a false air bone gap. And then obviously the crossover hearing that we find on those. So that's just, I know it's a bit of a busy slide. And a lot of you are saying, Duane, this is a bit of awkward. This is the audiologist would know this. Yes, they do, but not all of them put it into practice. So just be careful. And you can see I've written high risk on the high frequencies, high risk on the very low frequencies. You can really rely on most airbone gaps in the middle frequencies between 500 and 2000 hertz, but not so much in the low frequencies. So at 250, the artificial mastoid is poorly matched to the human skull and contributes to calibration errors. At 4000 hertz, the artificial mastoid resonance characteristics diverge from human data, and that gives us a variability of up to 5, but it can be a lot more than that. The International Standard of Operation Standards provides no bone conduction calibration reference values above 4000. So any audiometric testing at 6000 and 8000 via bone conduction, that's not standardized and that's not really accurate. So be careful in those high frequencies. All right, just quickly another word on that harmonic. At a maximum output, the B71, that's the bone oscillator, produces a second harmonic distortion at of about 20% at 250 hertz. So a patient with near normal hearing at 500 hertz may respond to the 500 hertz harmonic at a 250 stimulus, and that produces a false bone conduction. Remember, insufficient maximum output, I did talk about that. That's where the bone conduction output can only be about sort of 40 on average at 250. So if you've got a sensory neural hearing loss at about 70 at 250, you're going to get this air bone gap. That's false. Be careful about that. And then, interestingly enough, obviously the bone conduction threshold elevation from middle ear pathology at 250. So true sensory neural hearing loss at 250 is relatively rare. And we see that the frequency, the bone conduction threshold elevation should prompt consideration of a couple of things like the endolymphatic high drop, superior canal dehiscence, etc., etc., etc. So just be careful of that. And there's that graph again to just remind you. All right, the occlusion effect. Now, all of supraoral, only that word just means headphones, is placed on the non-test ear during masking. The occlusion of the external canal enhances the bone conduction thresholds in the low frequencies, up to 20 to 25 decibels. And that prevents the sound energy from normally that radiates from the open canal, and it actually sort of gets bounced back and it increases the bone conduction threshold. So just when the canal is occluded or even a tightly fitting insert, you get that radiation of sound into the canal, and that's trapped, and that augments the bone conduction. Just interesting that it can be up to 20 to 25 decibels at 250 hertz. You've got it at 15 to 20 at 500 hertz and about 5 to 10 at 1000 hertz. So you can see that the 500 and the 1000 hertz, a lot more safer gap to believe on the audiogram. I just thought I'd give you a quick 3 little examples of what the harmonic distortion is. This is just, I'm not going to go through the whole thing for sake of time, but here you can see on the audiogram, we've got what appears to be an airbone gap at 250, quite a large airbone gap, which looks like actually 10, 20, 30, almost, from 5 down to 45. So we're almost sitting at a 40 decibel airbone gap, and that's just a poor harmonic. So that is false. And obviously we're going to test it with a tuning fork. We're going to talk about that in a second. This is the one, and the older adults that we find on the left, you can see what the audiogram looked like, and it's got this airbone gap that you can see clearly. And then if it's correctly masked, you see that you get that properly masking, and then the bone conduction actually comes down, and you can see here on the right hand side, that is actually how that audiogram should look. And so that false airbone gap has now been eradicated, and that's the correct audiogram there. So be careful about sensory neural hearing loss in the high frequencies. Anything above 4000 is risky to take. And then again, the occlusion effect. And this was just an interesting case because you had this patient in 2012 with an pure tone average about 85 decibels if we look over here. And then by 2016, this is down to like 105 decibels. But it looks like the bone conduction actually went up, or possibly made this gap and we can think there's an airborne gap. Remember, that's just the limits of the audiometer. It actually can't go lower than that. So be careful. Those are not airborne gaps. Those are just false gaps because of the audiometer. Enough of that. Let's quickly jump to my favorite topic on tuning forks. Always a cross check against any false airborne gap. And I think the core value of a tuning fork is that they instrument independent and calibration independent. They bypass every source of error that we've just discussed. So they'd provide us with a direct phase-based assessment of the air conduction and bone conduction relationship using the patient's skull as the medium. I know they remain clinically undervalued precisely because they're perceived as low tech. And there's a prominent professor that comes and visits South Africa every now and again that believes we take the audiogram over and above a tuning fork. However, I think us as South African audiologists know that, well, otologists, sorry, I know that the tuning fork wins. And certainly in my hands, I'm much more comfortable believing my tuning forks than my audiogram. I've been caught out before because sometimes the tuning fork isn't so clear, but I like to take the two together. I do think just be careful of that C1 tuning fork. It's vibrotactile rather than auditory. And really, guys, we can't just sit with a C2 tuning fork and think we're doing tuning forks. As an otologist, you need a C1 to C3. Okay, just a reminder there. So remember, the 512 correlates very, very closely with the 500 hertz audiometric frequency. And so anything there that shows us a false airborne gap can be quickly tested and confirmed with your audiogram. Again, just a reminder that the 250 is usually a vibrotactile sensation. And then the interesting thing, the C3 fork is more sensitive for detecting small conductive losses, but it's less commonly used in routine. So it's good to use all three in conjunction. Let's move on. These are the things we're not supposed to be discussing tonight. So this is middle ear effusions. Middle ear effusions, we know about that. I'm not going to talk on that. That can give us up to 30 decibels in some cases, depending on the viscosity of the fluid. We know what to do here. And just remember the barometric trauma, the barotrauma that can give you that hematuria and can give you a similar effect. This is the interesting one, external ear canal occlusion. We know wax can give us huge airborne gaps. Don't forget casts, those dried. We're seeing it less with the drops of today being different, having different consistencies. But every now and again, you get a dried out sort of debris cast, and that can give you quite a significant airborne gap. Keratosis obturans as well on foreign bodies. But the one I just want to mention shortly is medial canal fibrosis. This can catch us. We see the ear canal. We say, oh, this is a very swollen ear canal. We go to theater. We make an incision. Man, this thing bleeds and it's thick and it's granulation tissue and you can't really get the grommet in. It's too short. Actually, possibly you've missed a medial canal fibrosis here. This is one of my patients, and I'm going to actually show you the the CT scan right now. He had a mild medial canal fibrosis on the left and a larger one on the right. Let's have a quick look there. There you can see that medial canal fibrosis thickened drum. That's only about 3-4 millimeters max, maybe not even that much, 2-3 millimeters, and you can see it disappears. But then you look on the right-hand side, and we've got a lot more significant one. And obviously, the bigger you do get, the bigger the airborne gap. There's a limit eventually. I don't think it can go bigger than 45. But there it is. Okay, so that's what it is. This is another case of mine with quite a significant medial canal fibrosis bilaterally. And these are the guys that actually probably needed surgery. And I did take them to surgery, but they can recur. So these aren't great. Even if you put this tiniest, thinnest split skin graft over there, these do recur. And so one's fortunate. We've got about a 61% success rate, not a great success rate in terms of coming back. You'll notice, and maybe I can just point it out if you can see, if your screen is big enough, there's the tip of the scutum, and you always find in the superior aspect of the drum, there's usually a small gap. And so if you're coming down and you're going to remove this, we obviously want to be very careful when you go down with the granulation tissue. We don't want to damage the tympanic membrane, and we want to find that tympanic membrane because that's really a friend in this disease. So go always superiorly first. You'll find the tympanic membrane better there because there's usually this little gap. You can see it on both sides. Not always there, but it's very nice when it is there, and I've seen it in most cases to be there. So if you are going to repair those, look for that little gap. It's very helpful in finding the tympanic membrane. So after that introduction, what are we actually going to talk about today? Well, we want to talk about treatable causes of ossicle abnormalities that give us a small airborne gap. We're going to discuss a few congenital causes as well as some traumatic and acquired causes of small airborne gap. I've divided it pretty much into malleus-related causes and stapes-related causes. I haven't included incus, probably because it's a very rare, but yes, there are a few. I have, I think, two just primarily fixed incuses in my practice. Probably both of them were tympanosclerotic related. And then there's a caveat or two that I'm going to discuss at the end. So let's move on. Malleus head fixation. Well, this is a little bit more than meets the eye. We've got the House or the Goodhill syndrome. I'll discuss that in a second. We find these malleus head fixations usually between the ages of 25 and 30, or also let's say under the ages of 30, because they're usually congenital. But chronic suppurative otitis media can lead long-term to a malleus head fixation due to chronic ear disease. It can be post-traumatic with fractures and neo-ossification, and then tympanosclerosis or neo-osteogenesis can also cause it. Then the very controversial superior mallear ligament, as well as the anterior mallear ligament. Ossification of these two ligaments, could give us significant, according to Hugo Fish, hearing loss. Please, Hugo, I have the deepest respect for Hugo Fish. However, in his discussion of this, he says this is up to 30% of ears. I have not seen that in my practice. We discussed it at length, often at the course clinic, and none of the guys have seen this. I'm not saying he hasn't seen this in his series, but in my experience, I do not see this. But I'm going to talk a little bit about this a little bit more in detail. So if we only have an isolated malleus head fixation, the airborne gap is sometimes less than 25. We often think we see that large airborne gap in the low frequencies. Oh, this must be malleus head fixation. If you fix it just on the one side, the umbo is right on the other side, and that can still vibrate, even though there's just a little bit of fixation, right across at the head of the malleus. And that's why I don't think we see this as dramatically. I think if you have the superior malleolar ligament, if the superior malleolar ligament is ossified, you've got a big osteoneogenesis anyway, so that's not a problem. But the anterior malleolar ligament, if that's ossified as well as the head fixation, you probably can go up to about 45 decibels. We have got a case like that I'll be showing you a little bit later. So preoperative, the diagnosis of malleus head fixation can be made consistently with a pneumatic otoscope. Nonsense. I don't know how many of us have even got that little pneumatic little otoscope that you can actually squeeze some air in. I know some of you are sitting there going, Duane, I can do it. But I tell you, I've tried so many times and I go, yeah, this is definitely a malleus fixation. I can see it's not moving. And I do a CT scan, it's totally normal. And at surgery, I find something else. Or I think, no, this malleus is moving enough. I go to theatre and I don't bother about doing a CT scan because I'm sure this is otosclerosis. And I go in and my goodness, I find a malleus head fixation. So guys, pneumatic otoscope in my hands, I'm not very good at it. Maybe you're better. So don't feel bad if you're not getting that one right. I think cone beam remains our gold standard in diagnosing malleus head fixations, and we're going to show you a few views here. Always better to check it in the axial orientation. So coronals, you can miss it, and I'm going to show you a case that I did. When we look at superior malleolar ligament ossification versus malleus head bony fixation, we probably find they're very much an overlapping entity because there's neo-osteogenesis in both of them. But I've got a nice differentiation, which I'm going to show you now, between the axial neo-osteogenesis and just a malleus head, superior malleolar ligament fixation. Okay, you can get, when you find a malleus head fixation, obviously the incus by association is usually fixed as well, especially in the neo-osteogenesis cases. However, if it's just a malleolar ligament, it's not going to be involved. But I'm not going to discuss the incus now. The common technique that we've all been taught, if you find a malleus head fixation, is to amputate the neck, amputate the head of the malleus at the neck, and you remove the incus and you remove the malleus head and you do an incus interposition. And essentially that works very well. I will be showing you a little bit different. I have presented this before at the Congress, so some of you might have seen that, where we use a laser and we do a little bit differently and then use a bit of ketochem. But we don't want to make this talk about ketochem. We want to make this talk about small airborne gaps. I've specially made the slide busy because I don't want you to really read it too much. It's just the malleus ligament ossification as opposed to the malleus head ossification or fixation. And we must remember that Victor Goodhill in 1966 and Howard House in that same era did not have access to CT scans. So these guys would go in and they'd find a fixed malleus head syndrome. They'd look and they'd do a cortical mastoidectomy, get down to the malleus and find it all fixed and release it and get some sort of result. Howard House and Bill House would often open a middle ear because at that stage it was just the floodgates open when they defined this and sort of looking for otosclerosis on their stapes, and then they suddenly find, oh no, the stapes is mobile and primary malleus head fixation, and then having to work from there. So that was called the House syndrome. And so those two conditions have really been very much usurped by the fact of cone beam CT scan because we can have a much better effect now. We know where we are. These are two great articles. One of them using a really clinically a clinical modeling to actually be able to see what really is going on. And I think that's really a helpful article to look at. Sorry, I see my picture has gone over the writing over here. Just a reminder what we're talking about. If you can see my cursor over here, that's the superior malleolar ligament. That's the anterior malleolar ligament. And if you look at it, the superior malleolar ligament, if just the ligament is ossified, you can see that you're going to still get, just by means of the fulcrum, you're still going to get quite a bit of motion at the umbo. And that's why you don't really get such hearing loss. And if you've got an anterior malleolar ossification, you have a normal movement of the head, you're going to get sort of that rocking action, and it doesn't really lend itself to such a big air-bone gap. So the study that was done, and it was really well done, is, and we're looking on the left-hand side, this is the view that you'll see when you do a cortical mastoidectomy down to the malleus and the incus. Obviously, over here you've got the incus and the malleus head. And what they did was they used a little bit of geltrate, which is sort of a fixated, little soft fixative. And that's just to sort of show, you sometimes see in the malleus area, you've got that soft tissue over there. We sometimes think maybe that's a cholesteatoma or granulation tissue. How much does it really affect the malleus? Strangely enough, less than 5 decibels. So that really doesn't have much effect. A cement bar in a small area that was trying to sort of mimic a superior malleolar ossification. And they then tested the mobility at the incus, at the stapes footplate, and then they did a real neo-osteogenesis cement, sort of fully cementing that malleus head, and then retested this. This is Huttenbrink's work, a lot of Huttenbrink's work, and a lot of the other guys really did a good job here. So what can we talk about in terms of malleus, causes of malleus head fixation? So congenital development abnormalities, that was at that stage called Goodhill syndrome. It's still called that nowadays. Chronic middle ear inflammation, I haven't seen that so much. I've seen more tympanosclerosis, which you could probably say is a bit of a chronic ear disease. Tympanosclerosis and this osteoneogenesis or osteogenesis of the bone, those are the ones I've seen mainly. I have got 1 or 2 patients that have had prior trauma, but it's quite rare to have that fracture just through the head there that'll then cause secondary ossification. Remember, we know that the otic capsule doesn't ever heal completely after a fracture. So it never really seals. And so that doesn't often find, or I don't often find that extra bony formation forms and then causes that head to fixate, but that's what the literature tells us. And then they talk about rare conditions like otosclerosis and ectopic calcification. So I'm going to present this patient. This is a patient that came to see me 4 weeks before her wedding. She really wanted this operation done. She, usual case, didn't have the funds to do a CT scan. And I said, well, look, this is a conductive hearing loss. It was C1, C2, Rene negative, as well as C3 plus minus. She couldn't decide if it was anteriorly or posterior, so we put it a plus minus tuning fork for C3. So that for me felt that was good enough to go and do an exploratory tympanotomy. This is the exploratory tympanotomy. Excuse my hand a little bit in the way, and I realized that we could have done this with an endoscope, but I didn't have that set up. So what I'm doing is I'm palpating the malleus, and immediately I can see that there's a fixation of the malleus. So this is a little bit daunting. You can really see that malleus is not moving like it should. And so to just save time, I'm going to explain what I do. So the first thing I then do is I go and open up to try and see if this is the anterior malleolar ligament that's extra, calcification. Maybe there's an attachment directly to the malleus head there, and I can loosen that up. And so that's what I'm busy doing here. I eventually then pass in this area over here, I'll pass a 90-degree or a long 45-degree needle, and I'll rotate it through there. And if that is loose, I know that cannot be fixed over there. And then I know this is a head fixation. Okay, so she then came back. We rebooked her after a wedding. She came back a couple of months later, and then I admitted her to hospital just a few hours before the surgery, and then we were able to do a CT scan. And this is what you see on the left-hand side. But that is all you see. You see on the left-hand side, is there something? Oh, sorry, the right-hand side, is there something going on? But the left-hand side, that's the only view I've got with an attachment, and the rest looks pretty free. So don't miss it. That's the audiogram. It didn't change. And this is now the second operation. I know you're saying, Duane, you should have done this at the first case, but I just felt I hadn't discussed this with her, and I didn't want to shave her hair and give her a post-auricular incision 4 weeks before her wedding. So you can grill me on that, but that's what my decision was. So here we go with a nice endoscopic view, and we're going to look down there. We can see the malleus over here. We can see the incus over here. And it doesn't look like it's just a ligament fixation. This does seem to be that this is a bit of neo-osteogenesis. I'm going to mobilize or try and show you that the movement of the incus. Now, those of you that do cochlear implants will know that if you touch the incus in that area, it's going to move a lot more. So what I did was I then lasered. Now, I know you're saying, Duane, you're lasering very close to the tegmen. Why did I do the laser there? The laser was done because initially, my gut feeling is if I go in there with a drill and I've got osteogenesis, the bone is attached there, man, I could just as well be drilling on the malleus head and I'm going to get a sensory neural hearing loss. So I try and separate as much as I safely can. And given if that tegment is really thin, you've got to be very careful you don't heat up the dura and very careful in that area. But this case, we were fortunate. So I would laser, then use my 90-degree hook to just sort of fracture the bone a little bit, laser, fracture, etc., etc. And eventually, when it came apart, I could then use my drill to just clean it up a little bit. So I'm just going to show you a little bit for sake of now you can see we've actually loosened it and that whole ossicle complex moves a whole lot better. It was still a little bit tight anteriorly, so we went anteriorly and we removed more around the edge, and now we could move. You can see that whole thing is moving a little bit easier. Was it because the superior malleolar ligament anteriorly was ossified? I'm not 100% sure if it was that or just part of the osteogenesis, but we've released it there, and this is what we have. A nice improvement over there. She's very happy and hearing better. And but in the same way, I just wanted to show you this case. So this is also this is an osteogenesis again of the malleus head, but somehow we've got this gap. It's a much bigger gap. Apologize. I like to do all the audiograms as authentically as possible. So this is just photographs of the genuine audiogram. I don't want to put digital ones in because, it might be seen as crooked. So this was her. She came from another venue, another St. Elsewhere. We always blame St. Elsewhere. But I had a coronal CT scan, and this is the exact coronal CT scan that I have. Now, the fixation, sorry if you can remember there, is on the left-hand side. So if you look on the left-hand side here, there, there's no otosclerosis, or, maybe no otosclerosis that I can see there, but certainly no malleus fixation that I could see. But the mistake was I should have done coronal. So when she got, when we realized that we'd made this mistake, this is not actually hers. This is a similar one, but this is actually hers. This was sourced from the scan later. You can see there's that little band just touching there. There's another one. I'll just show you that close up. So there's definitely, and you can't believe that this is there when on the coronals you can't see it. So just remember, that's what we saw in coronal. So I know I have presented this. I'm going to fly through it. Essentially, what did we do? We'll show you the video of the whole thing, but I'm going to talk you through it just to give you an idea. That's where the fixation was at the malleus head. So I used a laser to separate the malleus head from the neck of the malleus. And at the same time, with a little bit of heat, the incus malleal joint separates quite quickly. So you can put a little bit of heat over here and it pops right off, and the incus is very mobile. We then did separate the IS joint because we didn't want to overstimulate the mobile footplate. And then we caught what we call the magic bridge. That's that little nylon core. We put some ketochem nylon core between the two, and then I reconstructed the IS joint at the end. So that's what that looks like. We might just quickly play through this all. So again, definition, I'm mobilizing malleus now, or trying to mobilize malleus, and I find, stuck. Thick, nothing moving, but I'm getting an incus that can move, but stuck malleus. So we had already separated the IS joint there. So what I'm doing now is, this is very difficult to see because it's in a really tight spot. We're actually lasering through the malleus neck. We then, after lasering through the malleus neck, we got mobility of that malleus. And now we also made sure that the incus was separated. So you can see now, if I gently palpate, we have the head is still fixed, but the body of the malleus is moving. And there you can see nicely moving. We've already separated the incus. That was separate on its own. You can see I've just lifted it off. I'd already separated the IS joint. And now you've got a little bit of a sort of an overhang of bone. That's sort of that where the ligaments sometimes attach there. And that was touching quite nicely towards the incus. So I used that with a little bit of ketochem to join the two together, and then put my little magic bridge on top of that, and then just filled that up with ketochem. And once that was done and I was happy with that, we then went ahead and repaired the stapio, the IS joint. Again, we do that last because we don't want to cause a problem. I forgot to mention that on the other case that I always release the IS joint before I go and repair the malleus head. I will show you that now. So that was the end result or the end picture. And that was our audiograms. That was the initial one. That was post-op, which was a little bit disappointing. It was 2 weeks. It was flying back overseas. So I wasn't going to see her again, and I wanted to just see what it was. But I think it might have been a bit early. Subsequently, she did send me a pic, but it wasn't great for the video. But that's where the final 6-month post-op is. This is a 40-year-old patient with left conductive hearing loss. She noticed this in her teenage years. She felt there was always a curtain over her left ear, but she can cope in most situations, but she really wanted this sorted out. Look at that small airbone gap on the left-hand side. That's nothing really to snarl at. The only reason I thought about doing anything here was that she was C1 and C2 Rene negative, and again, C3 was she was actually Rene positive. So there was no doubt about the C3 tuning fork there. It was a closed airbone gap, but she had a significant C2 and C2 and C1 Rene negative, and that made me consider opening up. This time, obviously, we did the CT scan before the time, and this is all you see. So there we go. You can see what, similar to the other patient, almost looks like an ossified superior malleolar ligament. Difficult to say. There's a little bit of osteoneogenesis there. Can't really say. There's a little bit more. But I mean, if you look on the other side, that could also be construed as osteogenesis and a fixed malleus. And she's got totally normal hearing on that here. You saw now. On that, there's normal hearing. Well, not conductive hearing loss, at least. Okay. So this is the surgery. Again, we opened up. We realized that the malleus is fixed. We confirm that. What you don't see there is I release the IS joint. Now I go to the back and you're saying, Duane, that's moving actually very well. The incus was moving very well, but the malleus was very, very fixed still. And you can see over here, that's that superior malleolar ligament ossification, or that's what I'm calling that, just because you can't really see it. But now if you touch the malleus, that's very stuck to that promontory. So was this osteogenesis? Was this just malleus ligament, superior malleolar ligament ossification? Difficult to say. It doesn't really matter for semantics. What we want to do is gently laser that loose so that we can get normal movement of that malleus and incus complex. Just remember, guys, that I have released the IS joint. And now gentle palpation, and you can see the malleus moves beautifully as well, very easily now. That's been loosened up. And you can see I have removed all the char. And yes, there was a little bit of drilling down there. So just remember, the IS joint was released prior to the surgery, and we could now move the malleus. It was a little bit tighter. I went back and just released the anterior malleolar ligament a little bit, but actually this healed up very nicely. And sorry, I just put a little bit of ketochem on there. And that's our post-op result. It's not beautiful, but she was clinically a lot better, and her tuning forks normalized, even the C1. So that's the prior to surgery. That's the post-surgery. That was the audiologist. I'm not sure why she put Tipex over there, but she did. That is the results. Not brilliant, but clinically she was very happy with that. I want to just compare this to a bony bar. A bony bar is a bony bar that stretches really from where the chorda takes off, crosses the malleus, catches that long post of the malleus, and then goes sometimes all the way across the tympanic rim. So that's the audiogram of a malleus fixation due to a bony bar. So that's not a small earbone gap. I realize that, but I just wanted to quickly show you this. And there you can see, I just want to make sure I'm running short of time, so I don't want to talk too long. That was the bony bar. Just remember, in this case, the chorda tympani is over here, but in just a few recent weeks ago, we did another one of these, and the chorda tympani runs right through that bony bar. This is a left ear. So just for sake of time, I'm going to fast forward to the end. We lasered it loose. And now when you touch the malleus, everything moves very nicely. And you've got a nice reflex that's actually just the oval window, not the round window. And patient's hearing very nicely. So that was her result. Again, not a complete closure, which is interesting. I'm not sure why, but that was her result, but certainly a lot better. Let's move on. 57-year-old gentleman. They put their finger in the ear and they pop like that. One too many times. He said suddenly something felt weird. There was a strange feeling in his ear, blocked sensation, crackling noise was ongoing. What happened here? Now, you could say this could be an audiogram mistake, this little earbone gap, this could be the limit of the audiometer. But he had a C2 Rene negative, which I don't understand. Oh, sorry, a C3 Rene negative. And that is good for those small gaps, those C3 Rene negative. So I decided it was worth opening up this ear. On CT scan, we saw something quite strange over here on the left-hand side. And I thought, well, I've never seen this before. What if this is a fracture of the umbo? Is that possible? Well, This is the patient that we see here. If you see inside now, you can actually see mobilizing there, and you can actually see the umbo mobilized there, and the head of the malleus, they're not attached. I'm going to zoom up closer for you. You're going to get a better view of that in a second. But if I move the head of the malleus, it seems like the umbo is moving. But if you move the umbo or the long process on its own, so the malleus, the two move together there. But if you just move the malleus, it's not connected. Now you say to me, Duane, surely that can't give a hearing loss. Well, as you could see, it doesn't give a massive hearing loss. But I just felt, let's see what happens if we repair this. So for time's sakes, we just put a little bit of ketochem there. I did laser a bit because there was a bit of too much mucosa. So I did laser a bit just to make it a little bit more rough for the ketochem to stick. And then we attached that over there. And this was the pre, and that is the post. Not a huge difference. However, the patient was delighted because he said that funny feeling sensation is gone, the crackling noise is gone, and he feels it's back to normal. Okay, so that's the before, that's the after. Not a huge change. However, clinically, symptomatically, it was a lot better. I'm going to talk about a couple of the causes now of the stapes. I realize we've only got a few minutes, so I'm going to rush through this. Be careful of fractures of the stapes crura. They're very difficult to repair. I'm going to show you a few of those. The incudostapedial joint disruptions, those are the best, the tiny ones. Be careful of adhesions, not always going to give you that big a loss. Be careful of the partially fixed foot plates. So this is a patient that came from an MVA when she was 8 years old, 19-year-old girl. Nothing to see on the CT scan. I'm going to run through it for now. When you go inside, you actually find that she's got a fracture of her anterior crus of her stapes. This is a right ear, and you can see there is the fracture. It's difficult to see. I'm going to mobilize it now, but the fracture is right there of the anterior crus. There's soft tissue joining, but there's no bony joining there. If I go a little bit forward, you can see when we mobilize it in the one direction, it moves, but in the other direction, it doesn't move. So you can see that she's got sort of one direction, that moves, that doesn't move. There was also quite a bit of problems on the posterior crus as well. So we had to repair posterior crus as well as anterior crus. Sorry, I couldn't do this under endoscopy because there just wasn't enough space on the side without damaging the drum. So I did this with a microscope, and then we'll just look at the end result here at the end, just for sake of time. We go in, and there you can see we repaired the posterior crus as well. Put the IS joint back in nicely together. And you're only going to see a slight glimpse of this because I was just scared I was going to dislocate what I've just repaired. And so there you can see, there it comes through over there. There's the ketochem gluing the anterior, there it is, the anterior crus back together again. Okay. She actually got a very nice result. She still had that dip at 2000, but if you compare prior and post, her symptoms were much better and she normalized. This is a gentleman also with stapes discontinuation since childhood. And this is what we found. When you go in here, you can actually see very nicely when you mobilize the malleus, you've got a nice movement of the incus, and there's just no connection to the stapes. He's got sort of a congenitally abnormal stapes head, although the stapes tendon is split between the incus and what a stapes sort of superstructure. I'll come around the corner now and you'll see it a little bit better there. Again, for sake of time, let's just move on. I'm moving the stapes there. You can actually see, now I'll touch it, and the stapes will actually move. So we knew the stapes was very mobile. You can see a nice window coming through here, and round window reflex. There you go, very nicely. So we knew that stapes was moving, but there was just a discontinuation there, sort of a absent false stapes, and we just repaired that with a little bit of ketochem, and he was hearing a lot better after that. So that was his pre and post. Actually, quite a nice result considering what we had there. This is a gentleman with a standard incudostapedial joint disassociation. It's more just the diagnostic to show you that in the one direction, it seems like it's moving, but in the other direction, it's definitely separated. So when you lift it up, you can see incus moves, and it's not taking stapes really very well with it. Yes, there's definitely vibrations going through, but the stapes, even if you move stapes, it's definitely a little bit of discontinuation. Easy repair just with a bit of ketochem, and this is what you get. So that was the pre, that was the post, a nice effect. This is just adhesions of the stapes, but I realize that my time is coming to an end, so I want to leave some time for questions. This was just, I'm maybe just going to point it out, that stapes you sometimes find is adheres to that promontory over there. And this was quite stiff. It wouldn't move. Be careful. Sometimes, even though it looks adheres, it's still very mobile and it doesn't need removal. So I'm not advocating you go in here. This was a very clear, very stiff one that wasn't moving. And then we just slowly lasered that adhesion free. And then the patient had a very nice mobility at the end. That was the post-op. So pre-op, post-op, we had a little bit of a difference. I've just drawn the red in to show the improvement over there. So yes, this was probably tympanosclerosis in the area, maybe chronic, because she did have chronic ear disease, maybe a bit of chronic sort of scar tissue with maybe a bit of ossification in those scars. That gave us that. So just be careful. That is very possible to give us that little earbone gap, but really just be careful in those cases. One that I just want us to give a second look at is, here we go in and we see we've actually, this is the IS joint up here. So there's cauda, but there's the incus, and I'm actually going to palpate stapes now. Once I've released the IS joint, you palpate stapes, you think, oh no, this thing's mobile. Like you can't believe this is perfect. This can't be the problem. But we're not getting a round window reflex in any way when we move that stapes. And this is the fractured stapes crura. Be careful of that. It can mimic a mobile stapes, and you can miss either a fixed foot plate or reconstruct. You need to reconstruct the stapes. I've got another case exactly the same, or similar, and I'm again going to just fast forward a little bit. So you can see here when I move it there, although you can see the stapes moves nicely, that posterior crus and anterior crus are not attached. This guy needed a reconstruction with Ketochem. I've gone over my time. I haven't left enough time for questions, but I'm sure there might be a few. Ashen, over to you. Thank you.
Thanks, Duane, for that. I think it's a very interesting talk. I think we've got a few minutes if there are any questions. We've got about 5 minutes before we hand over to Darlene. I see there's a question in the chat to Duane. Lovely presentation and videos. What do you use for repairs? It's from somebody. I think you mentioned the Ketochem.
So I'm a little bit biased, Ashen, so I know this is going to sound silly, but I use a lot of Ketochem for small reconstructions because it's very handy. And I don't think I could have done a lot of these reconstructions without the Ketochem. So sorry, guys, I don't mean to preach Ketochem, but I'm a big fan of Ketochem. I do not want to rule out things like an incus interposition for a malleus head fixation. It still works well. And if you've got good experience with it, I think it's a great opportunity to use. Prosthetic wise, for these cases, there wasn't really a case that I needed a prosthesis as such. Yes, you could have maybe on those malleus head fixations done a little bit of a torque, but if you think about it, if we release the malleus like we did, we've got a more natural situation and we've got a protected ear. So I prefer to try and see as much as I can do without introducing a prosthetic, a titanium or a hydroxyapatite prosthesis.
Okay, I don't see any more questions in the chat, but Duane, it's also very interesting with these small airborne gaps. And, I think the question that always crosses my mind when I get them is, when can you do more harm? If you've got a 20 decibel airborne gap and if you create more of an injury or a sensory neural hearing loss, I mean, it's almost unforgivable. But I mean, I suspect that the more experience you've got, the safer the outcome is.
Ashen, I think all of us can still have a bad outcome. It's not a guarantee. And so if I've got a C1 and a C2 tuning fork that's Rene negative and a C3 dubious, I would consider opening it. I usually tell the patients, if I open an eardrum and put it down, I'm going to lose 5 to 7 decibels. So I've got to at least be able to make sure that I'm going to improve that. I say that, but in retrospect, we probably, if you lift it very gently and put it back, you're probably not going to lose much, maybe a decibel or 2. But be very careful that you gently palpate everything, that you don't over palpate, because it is possible that you cause a trauma. And it's happened to me before where I've gone in and I've said, oh, this stapes is so thin, this crura, and I gently palpate it and I fracture the stapes crura. Fortunately, we've got Ketochem to repair it, but yes, you've got to be very, very careful with those things. But I do think a good CT scan can give us a good idea, and I think we miss a lot of the malleus head fixations. I think they're more prominent there than what we think, even if it's a small thing, and that's easy to go via a cortical. Just quickly, you can do a exploratory TIMP just to release the IS joint, but then do a quick cortical, and you can release that very nicely and get a good result there.
And I think, one other area which has changed the concepts in conductive hearing losses are kind of bone conduction hearing aids, which are implantable hearing aids now, and the vibrant sound bridge, which you also do a lot of.
So those implantable devices are excellent, and I think more for our bigger cases, maybe those the cases we had to do a subtotal petrosectomy on, the cases where we have such chronic ear disease that we've got that atelectatic type 4, adhesive otitis media. Don't even bother trying to repair that. That's not going to work. You're not going to get that middle ear. So it's still, I know we talk about the eustachian tube aeration. Yes, the eustachian tube aeration is important, but sometimes as you get older, the aeration's fine. You might have done a dilatation. That's not going to change. If you've got a stuck down middle ear, that's not going to change. If you've got an adhesive otitis media, you can do what you like. The memory's there. It's just not really going to change. So be careful about thinking you're going to repair that. I would rather than go for an implantable device. And as you say, they're really, really good. However, in the same vein, give the patient the option of possibly going without the batteries. And I always say that, but I mean, just think, if you've got an implantable device, you're committed to batteries for the rest of your life in that ear, and walking through the airport going ping every time you walk through the Jolly airport scanner. So you're going to find that if you can treat the patient without batteries, hey man, they're going to be a much happier patient. And for those of you that don't do a lot of these implants, for example, the Ossia implant, the battery life is only a day and a half, maximum 2 days. The bone bridge is 6 days, so they're going to have to buy a new battery, regularly. Hopefully the rechargeables are coming out by the end of next year, but we'll see if that happens.
Just one last question here, which is, I think from one of an academic question for the registrars, I think. Would you advise exploration without a CT scan? I suppose this would means as a regular practice.
So I to my embarrassment, I have done it even with the advent of CT scan being available when the patient is just financially under pressure. I'm an old soul that just like feels so bad for the patient's financial position. And so in that situation, we'll either try and organize a pro deo CT scan if I'm really worried. But if I'm not too worried, I will do it in the cases. But I would recommend, if you can, it's a better used as a learning tool, guys. So if you do have access to it, and I realize it's sometimes difficult in public to get a CT scan, but if you can get a CT scan, it will help you a lot. However, there is a certain amount of experience that comes with time where if you lift an eardrum, if you see I'm going for a stapes repair, or it's not a stapes, it's a malleus, okay, close that, quickly go open at the back. I haven't really lost anything. If I'm gentle with it, I can probably get around it. You don't want to miss a third window in a semicircular canal dehiscence that would not have needed opening that ear canal. So that's the only thing and the only reason now that I do a cone beam CT scan on all my, if I can, all my conductive hearing losses. You don't want to miss it through a third window.
Okay, perfect. Yeah, so I think I see there's just one. Okay, just to clarify this last point, I think if you can get a cone beam CT scan, I think it's preferable these days. But obviously, if it's not available, high resolution CT scan, if you can get some magnified images, you could probably get some equivalent information. So I think we're gonna let Duane off. Thank you, Duane, for all the hard work in preparing that. So excellent talk, and I think we all learned a lot. Thank you very much.